So just to recap, I was a senior advisor on the SARS Commission. It ran from 2003 to 2007. And I was retained by the Canadian Federation of Nurses Unions to do an examination of how things have gone during the first part of COVID-19, and to do so using the lens of the SARS Commission and SARS Commission recommendations. So let's go to slide number 2, please. So, how do we measure our performance of how well we did? And, typically Canadians like to measure ourselves against the Americans, but these days, their pandemic response has been tragic, unbelievable. So it's a very low bar. Next slide, please. I think a better comparison is with our SARS peers. That is China, Hong Kong, and Taiwan. These 4 countries really were the hardest hit by SARS. So these 4 countries had 94% of all cases, 94% of all deaths, and more than 90% of all cases involving healthcare workers. Canada had the largest outbreak outside of Asia, and also had one of the highest infection rates in the world with respect to healthcare workers. So, all 4 countries, all 4 of us, had the opportunity to learn from SARS and put those lessons into practice. And unfortunately, China, Hong Kong, and Taiwan learned from SARS. We did not learn well enough the lessons of SARS. And, I'll just give you one small example. Hong Kong, for example, because of SARS, requires all of their long-term care facilities to have a 3-month supply of N95 respirators. That's a kind of detail that you see in Hong Kong, in Taiwan, and China, as lessons learned from SARS. Next slide, please. So when you look at how well we have done in comparison to our SARS peers, as I call them, we have not done well. And as John alluded, the national figures show that more than 21,000 Canadian healthcare workers have been infected with COVID-19. This is as of late July, and they comprise 19%, about 1 in 5 COVID infections in Canada. That's nearly double the global rate as reported by the WHO. But when you compare that with what happened in China, it's and the other 2 countries, it's stunning. Chinese healthcare workers comprise 4.4% of COVID cases, and most of those were before late January when they moved to airborne precautions. Same in Hong Kong and Taiwan, very, very low infection rates. And in the overall containment picture, we've also done not well when compared to our peers. Canada has more COVID-19 cases than China, Hong Kong, and Taiwan combined. We have more COVID-related deaths than China, Hong Kong, and Taiwan combined, which I find a stunning figure. Next slide, please. And how do we explain this difference between ourselves and our SARS peers? And I've used Justice Campbell's terminology here. Justice Campbell was head of the SARS Commission. He called it a constellation of problems. And I think there were really 6 issues that I'll talk about in more detail. Failure to follow the precautionary principle. Failure to critically evaluate the WHO's guidance and its performance. Failure to learn from China, Hong Kong, and Taiwan as they went through COVID-19 before we did. Failure to heed the pandemic preparedness lessons of SARS. There's been an absence of oversight and accountability over pandemic preparedness. Our our N95 cupboard, our cupboard for PPE was bare at the start of COVID-19. How did that happen? Was everyone asleep at the switch? These are issues that really need to be investigated. And finally, there's a real absence of worker safety expertise as an integral part of decision-making on worker safety guidance and strategy. That was an issue identified in SARS. It's an issue that persists. And here's an example between Canada and Hong Kong. In the early part of COVID-19, authorities in Hong Kong wanted to follow the WHO's guidance on public masking and avoid saying that public masking was important, even though public masking is more culturally permitted or accepted rather in Hong Kong. But some of the senior people who had been involved in SARS objected to the government of Hong Kong, and they changed their practice and very early on said that public masking was an important tool in preventing COVID-19. Next slide, please. So this is Justice Archie Campbell, the late Archie Campbell, who died shortly after the SARS report was completed. My great friend and mentor. And the core finding of the SARS Commission was the precautionary principle. And that is, where there's uncertainty on the science, you err on the side of safety. And, there are, as I will discuss, there are a lot of reasons why that came as an important lesson from SARS. Next slide, please. What the precautionary principle means in practice is that when you face a new pathogen, a disease like COVID-19 that we really are still trying to figure out, you err on the side of caution. You protect healthcare workers at the highest level, and then you only scale down that protection when you're certain that it's safe to do so. And the precautionary principle is not just about healthcare workers. It also extends to things like other containment measures like border closings and public maskings. And also being open to the fact that a new pathogen is new and unpredictable and can act in ways that we've never seen before. Like, for example, the high level of asymptomatic transmission among COVID-19 cases. Next slide, please. One of the things that has left me gobsmacked is that during COVID-19, we're having the same debate that we had during SARS about whether we should protect our healthcare workers with N95 or higher or equivalents, or whether surgical masks are sufficient. What occurred during SARS is that the best evidence that SARS was spread through aerosols didn't come till after the outbreak was over. And Justice Campbell observed that what those studies showed is that they validated the leadership of the SARS response in Ontario that ended up requiring N95 respirators, though that was very problematic. But that in hindsight, it was a good thing that we went for a precautionary approach. Now, fast forward to COVID-19, we're in a very different situation. And as John knows better than anyone, the evidence of potential aerosol transmission now is significant and far more than we had during SARS. And so in a precautionary approach, the evidence is overwhelming, not demonstrating a certainty that COVID-19 is spread through aerosols, but certainly supporting decisions to protect healthcare workers at the highest levels, as opposed to waiting until there's this overwhelming certainty. Next slide, please. So I want to touch on some of the evidence that Justice Campbell relied upon when going to when recommending the precautionary principle. Some of the strongest evidence came from British Columbia. As it happened, the index SARS patients in Vancouver and Toronto presented on the same day within a few hours of each other. I mean, it was, for an investigator, it was an incredible situation. And what happened is that at Vancouver General, the index patient was isolated within 5 minutes. Staff went to airborne precautions within 15 minutes. And I think the consensus is that those actions really made a huge difference in ensuring that British Columbia had only 4 SARS cases through the whole epidemic. In Toronto, the index patient went to Scarborough Grace, was not isolated for 21 hours. Staff did not have N95 respirators. This really led to the Toronto outbreak. And there was some grumbling amongst some people in Toronto that, well, Vancouver was just lucky, and I think that was an unfortunate way for them to look at it. But Justice Campbell said, if they were lucky, it's because they made their own luck by taking a precautionary approach. Next slide, please. We also failed to learn from the Chinese experience, and here, the WHO bears a huge amount of responsibility, and this is something that John and I have talked about. So, in late January, China noticed a real uptick in infections among healthcare workers. And until then, China had by and large been following the WHO's guidelines, which we are following, of saying that contact and droplet precautions involving surgical masks were sufficient. But this uptick in China led them to say, no, we've got to go to airborne precautions. So on January 20th, the Chinese authorities ordered all healthcare workers to go to airborne precautions. I know John can comment more technically on what they did, but effectively, even though the science didn't prove that aerosol transmission was a factor in COVID-19, they took a precautionary approach and protected their healthcare workers as if it was. And what happened? Well, rates of infection among healthcare workers dropped. And China sent 42,000 healthcare workers on an emergency basis to Wuhan at the height of the outbreak. All wore airborne precautions. Not one was infected with COVID-19. Stunning. Now, concurrently to this, the WHO's China mission was there investigating and published its report. Now, in its report, in the body of the report, what they say is that China has done, our findings show that China has been able to ensure that its healthcare workers are protected, and that its healthcare settings are also well protected. But in the body of the report, they never say how China did this. To find out that China actually went to airborne precautions, you have to look at the back of the report. Buried in a technical annex is the fact that Chinese healthcare workers wore N95 respirators. Now, I find this bizarre that WHO never came clean and said, China has gone to airborne precautions. Why they did this, I don't know. Some have speculated that it's because it would have called into question the WHO's own guidance, which was surgical masks and contact and droplet precautions. So I think some experts have speculated that if the WHO had come clean and raised this issue at the time, it might really have affected the course of the COVID containment and spared lives. the misinformation on what happened in China is remarkable. There was a recent article published by a leading Canadian expert who also consults with WHO, who misconstrued what happened in China, and he suggested that in fact healthcare workers were infected who wore airborne precautions, when in fact the evidence is otherwise. And I want to commend John for writing a letter to the journal correcting that. Next slide, please. You know, there's a real difference between the Chinese government and its authoritarianism and Chinese researchers and medical doctors who, in my experience, I think experience of many people, have tried to tell the world what was going on. I mean, Chinese doctors published letters to the Lancet very early on, warning about asymptomatic transmission, published studies to that effect, warning that, airborne precautions are really necessary. But, we in the West did not take them seriously enough. And, Richard Horton at the Lancet and some others have said, it's Western arrogance and Western exceptionalism. But I think that, we need to really evaluate how we regard experts in outside the West who have, great insights and great capabilities. Next slide, please. And one of the issues I think we need to examine is that Canada has been too uncritically adhering to the WHO and its guidance. Canada has been in lockstep with WHO, and there doesn't seem to have been any kind of critical questioning of whether that was the right way to go. So, for example, on border closing, we told the WHO line for a long time until finally we decided to close borders. But our health officials and politicians parroted the WHO's arguments that saying that border closings are inappropriate. I never understood it, and they never explained the basis for that. Same on public masking. There was such a reluctance here, to go to public masking. Again, citing the WHO. Now, public masking is recognized as being part and parcel of our containment strategy. I think we need to realize what is good for the WHO is not necessarily in Canada's best interests. And we need to separate, part of the problem is that we have the same experts sitting at the WHO, Canadians, as here in Canada. And, decisions made by the WHO are for a global audience in very different circumstances. And we need to really look at, critically evaluate rather what the WHO says. Next. Thank you. So I think, one of the real issues that I hope we begin to look at is what is the basis for WHO and PHAC and other public health agencies to make their decisions. So, whether it's airborne transmission or public masking or border closing, they require the certainty of randomized controlled trials. Now, that's certainly the way to go for drug and vaccine safety and medical procedures, but not in worker safety. There are no randomized controlled trials in community settings of hand washing or social distancing or closing schools or quarantining or things of that nature. We have to rely on what have been called as, natural experiments in this regard. Next slide, please. So on airborne transmission, this is an area that John knows far better than I do. But this dichotomy is really most evident in the debate about the possibility of airborne transmission. So WHO and PHAC, they want complete certainty that you don't find behind their recommendation for hand washing or social distancing. But worker safety experts say the point is not certainty, it's safety. And I've quoted the June 2020 letter by 239 experts at WHO who said that in our collective assessment, there's more than enough supporting evidence so that the precautionary principle should apply. And that is such a great divide in dialogue. On the one hand, PHAC, WHO, all say the level of certainty is not there. Worker safety experts say there's more than enough evidence to take a precautionary approach. Next slide, please. In fact, as Dr. Maraska has pointed out, on terms of aerosol transmission and protecting healthcare workers, the kinds of randomized control tests that they want are really not possible or ethical. Next slide, please. I think one of the failures that really stunned me and continues to stun me is our lack of pandemic preparedness. The fact that we didn't have enough N95 stockpiled. This was a lesson of SARS. We never had enough N95s. We didn't do fit testing, of course, but that's another issue. And what saved our bacon during SARS was that SARS did not affect the US. And so we were able to just vacuum up all the N95 respirators that were available. But the lesson of SARS was that Canada does not manufacture, or until recently did not begin manufacturing 95s. We needed to stockpile because we didn't have our own manufacturing, and that was one of the recommendations of the Commission. But that was a lesson that was just not heeded. When you look at the Canadian Pandemic Plan, which came out in 2006, the same year that Justice Campbell finished his report. There's a lot of detail in there on antivirals and vaccines and lab testing, but there's nothing except for a brief mention on PPE stockpiling. And what that demonstrates is that health worker protection, the equipment needed to protect health workers was not top of mind. And since the pandemic plan was initiated in 2006, there've been all kinds of other plans. There've been all kinds of other studies done by the medical establishment, by public health officials. But there was a real absence of people asking the question, do we have enough PPE? If not, how do we fix it? Ontario destroyed as many as 55 million N95s a couple of years ago. Last year, the feds destroyed 2 million N95s. But no one asked, what do we do now? Do we have enough? What does this do to our preparedness? And in fact, I was quite stunned when you read some of the comments earlier this year by chief medical officers of health. They seemed to be surprised that we were having these N95 shortages. One of the things that Justice Campbell recommended was that chief medical officers of health have the right and independence to comment on public health issues. And they have, on obesity, on smoking, and all kinds of matters. But what's stunning is that no one, to my knowledge, and we've done research, publicly said, we're not ready for the pandemic. We don't have enough PPE. We have to do something. They were all silent. So one of my recommendations in the report that I've prepared is that chief medical officers of health have on an annual basis to certify the preparedness for an infectious disease public health emergency, including PPE. And it's a bit like what the chief anti-money laundering officers have to do at our big banks. They have to certify their anti-money laundering measures, and they have to be personally responsible. That's a for that certification. So I think we need to move to that to that moving forward. Next slide, please. John talked about the diversity of expertise in his organization, but the expertise that's being used to make the decisions that affect healthcare workers is really narrow, both at the WHO and PHAC. And this comment by Dr. Benedetta Allegranzi really speaks to that bias. She said, basically, we can't trust engineers or aerobiologists or others to tell us what to give us the facts about airborne transmission. And I think that bias is in Canada. And I think next slide, please. I think what we need to do is move to a model like NIOSH, like the model of John's organization, because the issues of protecting healthcare workers are complex. And epidemiology, infection control, while they're very, very important, are not the only disciplines that we need to bring to bear in understanding what we need to do. We really need a multidisciplinary approach that includes a wide variety of disciplines, like at NIOSH and like at John's organization. One of Justice Campbell's recommendations was that we needed to have a NIOSH-like body as an integral part of PHAC and other public health agencies, so that expertise is right there. So with that, I'll finish my presentation, and thank you very much.
Thank you, Mario. That was excellent, as anticipated. And I know from the time we have a few minutes at least for questions for Mario and, of course, John and Peter, if anybody has any questions. Maybe seeing no one jumping on my invitation, let me just suggest one topic that Mario, you might address, and it's your presentation understandably is focused on the healthcare sector, but naturally there'll be questions about how more broadly what lessons can we also learn and apply beyond the healthcare sector, and one that comes to my mind is this public masking example that you raised. I remember vividly my own personal reaction to the notion that we weren't going to be able to go to the workplace whenever I wanted to go, and we were going to have to change our routine. God forbid we change our routine. That aversion to change, and of course, masking in North American culture, I think, probably had that same sort of visceral reaction, or people had that same sort of visceral reaction. I did. I think others did as well. So I wonder, to your point about the precautionary principle and so on, do we also have to do a better job of getting ready for the next pandemic now? Like, do we need to culturally and from an education perspective and from a workplace procedures perspective really need to ensure that the lessons from this pandemic are baked into our workplaces so that we're not adverse to the change, we're ready for it?
That's a great question, Matt.
Mario,
and I think that the report that will be coming out in the next week or so, my report, was done for two reasons. One is that because I wanted to get recommendations finding out before things get really bad in a second wave, but also, as you've pointed out, for long term. Let me just talk about societal change, which is what we're talking about here with public masking attitudes. Is that I think that our public health leadership has done a terrible job of education and transitioning. So, for example, Dr. Tam went at great lengths to raise concerns that about safety of public masking, that people were going to self-infect themselves and not wear masks properly. Valid concerns. But what they have not done is they've not done a public education campaign on how to properly wear a mask. they've how to take care of a mask. In Hong Kong, in Singapore, and other places in Asia, they have television commercials. They have all kinds of videos showing you how to do it properly. And I see, and I'm sure you do too, people walking around in Toronto trying to do their best, but they leave their nose uncovered, right? Or they have a beard, and beards can interfere with the ability of a facial protection to protect you. So, it's we need to have better campaigns to promote these types of measures. For example, we need measures that reach out to younger people, to speak on their terms. They use social media to communicate about, how to wear a mask properly, why it's important, and to develop a sense of social responsibility. I think one of the things, I know our time is short, but I think one of the commendable things is that Canadians, by and large, have tried to do the right thing. We have this community spirit, which unfortunately we don't see south of the border. I think we need to really empower that, enforce that with the proper public education campaigns.
Thank you. Any last words from the face hair crowd? John, I see you've unmuted. Did you want to weigh in?
Yeah, I just wanted to say that your point is basically this is a teachable moment. People are now ready to learn these things so that when the next one happens, it's not something brand new and we're not unfamiliar with it. So yes, even some of the other controls like adjusting the HVAC system to allow more outdoor air in, this is a teachable moment. People understand why. So there are many teachable moments now, and I hope we take advantage of those.
Yes, I can remember doing a lot of this kind of stuff during SARS and advising employers on how to deal with that very unique experience, and yet not being really all that organized and ready when this pandemic hit, and being surprised that we might have to change our routines and wear a mask in public. That shouldn't have been a surprise this time after we went through SARS, should it have been?
And these new behaviors that we're learning are also good for the regular flu, for colds and other viruses. So this is something that we can benefit from in between pandemics also.